Hey, my name is Caleb Wynn, and today I'm going to be doing a presentation on clinical decision support by the CMS and discuss some of the impacts that it has on radiology. So I'm at the University of Emory in the medical imaging program, doing focused work in administration track. And so let's get started. So the objectives that I have today and for this PowerPoint are to define the basic concepts of clinical decision support, also known as CDS, examine the pros and cons of CDS, identify where radiology can have an input, describe the challenges of implementation and compliance in radiology departments, and we're also going to identify financial implications to radiology and health systems as a whole. So what is clinical decision support? Well, it is a computer software system, and it consists of computerized alerts, reminders for providers and patients, clinical guidelines, condition-specific order sets, focused patient data reports and summaries, documentation templates, diagnostic support, and contextually relevant reference information. So pretty much the goal of the clinical decision support is to cut down the unnecessary diagnostic imaging. This is estimated to be around 30% of all healthcare exams. And that is also, the heavy focus really is to high cost imaging. That's what the CDS tries to battle, because it's all about this low cost, high value, and high quality system. You know, they're trying to move away from the fee for service and more to a value-based system. And this pretty much really does that. So a little bit of continuation of it. It started because the Protection Access to Medicare Act, also known as PAMA, they wanted to require referring providers to consult appropriate use criteria, which is set by the ACR, American College of Radiology, prior to ordering advanced diagnostic imaging services. Services like CT, MRI, nuke med, PET scans, and this was all for Medicare patients, obviously. And so, you know, this is just a little diagram of just a little fun thing to interact. Like, it's got all kinds of different decisions, and you know, you put stuff in the monitor. You know, what do I do with the question mark and everything. So what is AUC? What is appropriateness useful criteria? Evidence-based guidelines to assist referring physicians and other providers in making the most appropriate imaging or treatment decision for a specific clinical condition. So they're funded and developed completely by the American College of Radiology. So essentially what you could say is the AUCs, the ACR collects data and information about exams, the complications of the exams, the costs from exams, the exposure from exams, and all kinds of different factors of exams, of radiology exams, specifically high-cost exams, and they put them together in this appropriate criteria, the appropriateness criteria, and it goes into this algorithm for the CDS. It uses an algorithm, and the doctor will type in information, and it'll be a list of things that he or she has to type in. And then in the study that I looked at for Aurora Health Systems, they would get a result of whether or not this exam was necessary or not necessary. So it would be from 1 to 10, 10 being definitely necessary and 1 being not necessary. You should probably check other options. So that's kind of what the AUC is. The ACR was named a qualified provider-led entity by the CMS, and that was in 2016, so that they could use the appropriateness criteria. And so that's kind of that's their involvement, and we're going to talk about radiology's input through that aspect as well later. So the pros of CDS. So this is from the CMS, Center for Medicare and Medicaid Services. It increases the quality of care, enhances health outcomes, helps avoid errors and adverse events, reduces cost, improves efficiency, boosts provider and patient satisfaction. So all of these things are supposedly benefits from the CDS. They say that if you're cutting down, the goal is to cut down the unnecessary exams. So if you cut those down and you pay closer attention through the software system, you're going to have a benefit and increase the quality of care and all these other things that come along with that. Some of the cons of CDS is implementation. So the theory or the thought of CDS has really been going on for decades, according to Greens et al. But it's been pursued and it's been without success. They attribute this lack of success to a lot of leadership issues, human factors, change, and we'll talk a little bit more about that into the problems with implementation. So some other cons are that studies show mixed findings on effectiveness. Some studies show that it's greatly, the amount of unnecessary exams is greatly affected by as much as like 20% or more. And then other studies have shown that its effectiveness is only about 6%. And the study that I looked at at Aurora Health Systems in Wisconsin, it was about 6% is what they found that it decreased the targeted exams. So yeah, like I said right there, and then we'll move on. So radiology's input. So we've already talked about the appropriateness criteria, and that's their role as the QPLE will give radiology an enormous amount of input. They will be crucial in determining which exams are necessary. So with the AUC and with the CMS and the CDS using that AUC, the criteria from it, this will give radiology a better role or a more impactful role in terms of the ACR, because they're directly involved with using and interpreting and implementing other criteria into the CDS process. So another thing, communication between radiologists and ordering physicians. As a part of this switch from a fee-for-service to value-based systems, the CMS and Medicare in general is really calling radiologists to switch from this order-taker culture. So the order-taker culture of radiologists and radiology in general is starting to become less and less, and it's pretty much faded out. They want radiologists to be in constant communication with with ordering physicians. So with this, it's going to be no different. They'll be talking about the necessary, after they put it into the CDS, radiologists may want to, further communicate with ordering physicians as to say, well, I know it said that this exam was unnecessary, but maybe we should look into it because of this. Or maybe it says that this exam is necessary, but the radiologist may know or have seen something or gotten experience in a different, in a related subject or in a related situation. So maybe they don't do it. So, it's going to be really required a lot of communication from radiologists and ordering physicians. So some of the other challenges, I talked about some of them earlier. So understanding of human interaction and workflow implications. So, human interaction that's been kind of one of the major lack of successes of a CDS, because we don't know if it's going to be rejected, we don't know how people are going to understand it, and we don't know how it's going to work. We don't know how people are going to like the workflow of it, or how it will flow through work and through workflow. So change, people are very, very not, the word I'm trying to use is that they're not very welcoming of change. Change can be just pushed away, can be resented, and just completely rejected in some instances. So also deficiencies in leadership. Many leaders in the healthcare system get there through clinical skill. It's not much they don't have the extended education or training needed to fulfill those spots. So you get a lack of leadership in management positions, and you really can't. And for leadership, it's providing the vision, letting your employees see your vision, and then working towards your goals and that vision. So there's a lack of that. There's also familiarity with the AUC. There's not a lot of it. It could be that providers are just not aware of the appropriateness criteria or something of that sort. And then communication among different software. So you're gonna need your software to communicate, and that's kind of an issue, and that's more of an IT issue. So, and we're going to talk about a little bit later, some of the things that you can, try to do to battle some of this. So, and then lastly, the financial implications. So reimbursement. Reimbursement is one of the most important implications of the CDS. It's dependent on healthcare organizations' participation in CDS. So if organizations do not have the CDS, reimbursement will be pretty much non-existent in terms of radiology exams. And so the loss of reimbursement, according to the CMS, far outweighs the cost of adopting this system. So essentially, it'll be in the best interest of organizations to practice the CDS, to implement it into their systems and to use it so that reimbursement will be full, or at least as much as it can be. Studies are also inconclusive about its economic impact in terms of healthcare organizations and radiology. Obviously, the cost per exam, or not per exam, but the cost of total exams are expected to decrease as the amount of high-cost exams decrease. But the estimated difference hasn't really been accurately determined. There's not really great information in terms of how much money a hospital will either lose or gain from this. So it's kind of hard to gauge that. So in conclusion, we talked about CDS. It's a computer program that helps battle the ordering of unnecessary high-cost exams. Working together with ACR allows proper guidelines to be set, and for radiology to be at the forefront of this implementation with the appropriateness criteria from the ACR. Implementation of anything new will always be a struggle, right? But with proper leadership, becoming familiar with the ACR's AUC, and a highly trained and skilled IT department, we talked about the software being able to communicate with everything, it will be made easier. It will be made more effective if those things are accomplished. It will be in healthcare organizations' best interest to comply with this mandate because losing reimbursement will be more costly than adopting this system. And then this does help the overall goal of shifting healthcare from fee-for-service to a value-based healthcare. If we're trying to cut down the number of high-cost exams, that means we're doing less unnecessary things, and that is going to in turn lead to higher quality care, because when you cut down those high-cost exams, you're cutting down radiation exposure, you're cutting down potential adverse effects, you're cutting down potentially contrast administration, which could help your kidneys or other functions of your body, and you're cutting down cost, which is one of the main focuses from the CMS. So the CDS is, it has shown its effectiveness. Some have shown little, some have shown a lot, but the fact is that it's here, it's coming in January 2020. So facilities and organizations, hopefully they better be ready to implement this process, because it will be very important for reimbursement in the future of their healthcare organization. Thank you.